Hello, everyone. Thank you for joining us in a new episode of our People Power Insights video interview series. Today, we have a very special guest because we are going to be interviewing a member of the new community that we launched recently, the Courageous Clinicians community. So, thank you, Kate, for joining us today.
It's a pleasure. Thank you.
Okay, so let's start with like the first question that we usually ask our guests. If you enter into a room like with new people, people you have never met, how would you introduce yourself?
Oh my goodness. Well, it depends on the context. Like last night, I attended a session on applying to college because I have the two teenagers, and I would introduce myself as Ren's mom. But if if it's a group of clinicians, I would say that Dr. Kate Tulenko. I'm a pediatrician and a health workforce expert.
Amazing, thank you. Now, some of the conversations that we have been having recently in the community and online are related to the health workforce. And before we go there, we can go there in a few minutes. But before we go there, I would love to ask you how and when did you decided to become a healthcare professional?
Wow. I think that probably happened my junior or senior year in college. I had majored in biochemistry and loved biochemistry. I felt like I was literally reading God's blueprints for life, but I found that the practice of it in the laboratory, it was all clear liquids and clear test tubes. It wasn't sort of close enough to people for me. And I literally went down to the college, career advisory center and started looking through the books of careers where I could combine my love of science with my love of cultural and anthropology. And that's how I came upon global health. And I found out that there were two routes to go into global health. One was becoming a clinician, mainly a physician, getting an MD, MPH. The other was to get a PhD in epidemiology or another a science like that. And it seemed to me that the MD was a lot more concrete. And so that's how I chose the career in medicine.
Amazing. Thank you for that. Okay, now let's move on a little bit into the health workforce conversation. When did that first like came up and appear to you like this is a topic that we need to start talking about, that we need to address?
I was very lucky in that my first year in medical school, I met Dr. Tim Baker, who was the founder of Johns Hopkins Department of International Health, which was the first academic department of international health in the world. And he was one of the founders of what then was called manpower planning in health workforce, a lot of which had come out of the rapid scaling up of medical schools and nursing schools during World War II and through the militaries, because so many health workers were needed to take care of the wounded on the front lines of World War II. And he actually taught a course on manpower planning at the Johns Hopkins School of Public Health. And I took that course, and the rest is history.
Wow. Okay. So then you learn about that. You knew that you wanted to get involved in that topic, and like how were those first steps, Kate?
Well, I decided to do my residency in pediatrics because looking at all the different medical specialties, pediatrics was the most preventive, in my opinion, with all the emphasis on vaccines, anticipatory guidance. Just prevention is really built into pediatrics. And while I was doing my pediatric residency, traditionally, because pediatrics is reimbursed at such a low rate compared to adult medicine, pediatrics has always been on the cutting edge of using non-physician providers. And my hospital actually had a committee of non-physician providers, and I became the resident representative on that. And my hospital, Children's National Medical Center in Washington, D.C., really had just wonderful nurse practitioners working with the cardiology teams, working with the NICU teams, the other specialty teams. And so that enabled me to continue my workforce work while I was a resident.
Okay. And then we also know that you wrote a book
Mhm.
about this. And you tell us a little bit how that book came to be. When did you got the idea, and how has like the story of the books been so far?
Sure. Well, I found that people, were looking at the shortage of health workers in, low and middle income countries, but also looking at the shortage in the US and thinking that they were two separate problems when they're
Hmm.
actually quite linked. And, no one really was addressing this. And it seemed the situation wasn't going to get any better unless, the root cause of the problems was addressed. And, writing a book seemed to be, one way to, draw attention to the issue. I had written some articles, but articles, rarely get a lot of attention. They're published for a second, then they're gone. They don't really have staying power, whereas a book tends to have a lot more staying power, especially, this was now, this close to 15 years ago. If they're published through either an academic publishing house or a general publishing house to get a lot more press, and so that's why I chose to do that. And so the book focuses on how the U.S. health worker shortage and maldistribution is directly connected to the global health worker shortage and maldistribution, and that you won't solve one until you solve the other.
Okay. Now, we obviously invite people to look for the book and take a look at it. But like, if you were to explain to us, like in a couple of sentences, in a couple of minutes, how are these two linked together? What would
Okay.
you tell us?
Well, unfortunately, the U.S. underinvests in training health workers from medically underserved communities. So this would be rural U.S. communities, the Latino community, African American community, Native American community. And because of that, we have a shortage of healthcare workers in the U.S. And rather than training Americans, people from those communities to be health workers, the U.S. has decided that it's cheaper to hire health workers from low and middle income countries. And so that's the solution that we've chosen. And, there are a number of myths around this. People think that the health workers that are recruited are unemployed, but they're not. They're usually the most talented health workers, in a country. In fact, the Gates Foundation around 15 years ago did a study of African medical schools, and they found out the number one cause of loss of African medical school professors is not retirement, it's not moving to another sector, it's migration. And the U.S. is the number one destination. So not only are we stealing the water, but we're smashing the pump. We're making it difficult for countries to train more physicians, after we recruit away their best and their brightest. And we see that in all of the professions, nursing, dentists, pharmacists. It really is a huge challenge.
Wow. And y- there are several like ways in which this could be addressed. And you mentioned some of those in your book, but could you share with our viewers what are some of those things that could be done to address the situation?
Absolutely. So the thing that the U.S. could do, within a year and start getting results would be to align public tertiary education spending with open jobs vacancies in the state. So, for example, Texas has one of the largest shortages of healthcare workers, and so Texas should look at the departments and the degrees where people have a hard time getting jobs, often are unemployed, and look at the industries where they have large vacancies like medicine, and take money away from those vocations where people aren't getting jobs and put them in to expanding nursing schools, expanding allied health professional schools, and medical schools. And so that doesn't require any new money. It's just a more proper redistribution of the existing funds.
I see. Okay. And now another thing that I wanted to ask you is, um, once, let's say, those kind of changes could be started, and and both the government and the trainees and everyone could get like doing these changes in their styles and in their work. Um, how do you think that this will have an impact? Like, what kind of like daily things could be seen as being like change?
Well, one of the first things hopefully we see a change in is that we are having actually an increase in maternal mortality and infant mortality amongst brown and black communities in the US. And about 1/3 of counties in the US do not have a single OBGYN or a place where a woman can give birth. So this is a huge crisis. And so by graduating more midwives, graduating more OBGYNs, we could make a huge impact on the health of pregnant women and on the health of newborns and babies.
Okay. And now you already mentioned some of the changes that like the government could do. Are there any things that the people like healthcare professionals could do like at their own capacity?
Absolutely. I've made a list of interventions that people can do if they have 5 or 10 minutes. A lot of it involves, reaching out to allied health professional schools, offering to be a mentor, offering to help reduce dropout if they have it. We know that in general, dropout is higher for people from medically underserved communities. This would be higher, rural areas, minorities. And by serving as a mentor, you can help prevent some of that dropout. And we know that you really can't backfill a position. So once someone drops out of nursing school, you can't put someone in his or her place. And, some work that we did actually in low and middle income countries showed that in many schools, up to 60% of people dropped out between day one and graduation. And the number one cause of that was financial. And then number two was academics, and then sort of social medical. So, having mentoring, also being able to provide scholarships in low and middle income countries, it's just $500 that's usually needed to prevent a dropout. So it's not a significant amount of money. So they're very small things that people can do. Also, if you're a nurse with a master's, you can teach. There's a huge shortage of nursing professors in the US, so master's prepared nurses, which is the number one bottleneck for training more nurses in the US. And so even just teaching one course or doing clinical teaching would make a huge difference.
Yeah, amazing. I didn't know that. Thank you for sharing that. And well, lastly, but you recently joined the Courageous Clinicians community, and we had some really like good conversations in those first few days. And I wanted to ask you, um, what kind of impact do you think these spaces, like the Courageous Clinicians community, could have on on clinicians, on health advocates, and the overall like community and population?
It can have a potential a great impact because it's going to be clinicians that are going to reform health systems around the world. Whether it's through direct action, through speaking to their representatives, speaking to their patients, changing the way they practice, starting private practices. There's a great amount that we can do, and I've really always been an advocate since I've been a clinician. I was active in AMSA, the American Medical Student Association, then the National Physicians Alliance, and so I was very pleased when I saw that Courageous Clinicians was launched to give me that opportunity.
Amazing. No, no, no. Thank you for joining. And finally, if you could give like one last comment or last piece of advice for people that are watching this video and that want to get involved and to do something, what would you tell them?
I'd say get active. You can make a difference. If you're interested in helping train more health workers, get in touch with me. I look forward to working with you.
Thank you very much, Kate, and thank you everyone for joining us in our new video in the series.
Thank you.